welcome everybody. We're going to start now. We have a speaker, Dr. Gregory Gom, and he's at his BA from UCLA in California. He's a psychologist. He has his PhD from SUNY in Stony Brook. Right now, he's the director of the National Center for Telehealth and Technology. And as he pointed out to me, this is a Department of Defense center, which is situated at Madigan. So he's not a part of the Army. He does his research in two different topics, in suicide and also in technology. He's going to tell us about his publications and grants as he goes on with his talk. And his UW connection is one son is graduated and one son already goes there. So, Dr. Gom, thank you very much.
Thank you. Is the microphone on? Yeah? Good for everyone? Okay. Hi. I appreciate the opportunity to be here. Let's see here. We'll figure out the technology first. As was mentioned, I am the center director, so I don't do a lot of real productive things. But Kevin Holloway and Greg Rieger do a lot of work in this area and helped to prepare the ideas for this and the material. Randy Heinrich, who actually has a UW affiliation, has worked for us under contract developing a lot of the work that you'll see when we get into the actual substance of this. Here's what I'm hoping to cover today. We'll see if we stick with it. We have a hard stop at 1. Yes. And we'd like to have some time for questions. Yes, so I will speed up or slow down as things work out or don't. Okay. I'm going to try to keep track with some notes here too. We'll see if that happens. If it doesn't, that's okay. So I recognize that you're not here to hear about our center, but as a relatively new center, I assume that most people probably have no idea who we are. So here's a couple of facts about who we are. We are one of the Defense Centers of Excellence. These were established to address the issues of psychological health and traumatic brain injury. We've been in existence for a little over 2 years. This says November, you'd say that's 3 years, but the reality is it's been something like 2 years. And we're a growing entity that exists primarily down at Fort Lewis. We have the mission of leading the development of telehealth and technology solutions in the specific areas of psychological health and traumatic brain injury to improve the lives of our nation's warriors, veterans, and their families. And to do that, we really develop, evaluate, and deploy technologies. So this is a notional depiction of where we're located, primarily at Joint Base Lewis-McChord, 40 or so miles down the road. We do have a small presence at the National Center for PTSD in Menlo Park. We have some presence in San Antonio, where a lot of the military headquarters are, and a fairly substantive group in D.C., partially aligned with the National Intrepid Center of Excellence, which is a new center there, and the Armed Forces Health Surveillance Center, which is one of the main data sources we have for working surveillance data as parts of our research. So as was mentioned, I have a slide in here that shows that we actually do research. Today's presentation is not really a research slide. It's really about a program that we have. So our research division is substantial, but it's not the main or the only thing we do. Let's see if I can keep up with my notes. What we do have is a range of publications. We consider ourselves to be reasonably productive as a new organization starting out. And we have been able to obtain some significant, in our opinion, grant funding that allows us to go above and beyond. We're primarily a core or hard dollar funded entity. So research funds bring ancillary opportunities to us. We're not primarily a research-driven center. I wanted to point out some of our key collaborations. We're not able to do all that we do without the collaborations, and so I wanted to acknowledge those here. It's really been thanks to Dr. Richard Veith and Murray Raskin, who aligned us and helped us to sort of affiliate with University of Washington, so they deserve the credit or blame for my being here today. But in addition, we have a project ongoing with that Kathy Bella is leading, aligned with a consortium through University of California at San Diego, and some other projects, as you can see here. This is probably about half of our actual affiliations. So we work actively. A lot of people have, we offer value in, we like to think at least, the quality of our research, but also in the affiliations to Department of Defense funding and resources of other nature, such as personnel. So, on to what we're here to talk about today. Virtual worlds. I'm going to come back to this, but I wanted to let you know what I'm going to talk about next is why we're doing virtual worlds. But I wanted to ensure that we all kind of knew what we were talking about or where we were heading. How many people in this audience have visited a virtual world? So, yeah, I know. No one wants to raise your hand. You're eating. You got food in your hands. Half? Is that kind of...
Do you know what this is?
What's virtual and what's real, I understand. We all struggle with that. Some days more than others. That'll shape some of the discussion, I guess, and we'll have some examples to help show that. Okay. So why did we decide to look at the area of virtual worlds? One of the challenges that we face is as we're faced with a growing demand for mental health care, and that's obviously in the news. You don't have to be a scientist studying mental health area to be aware of the challenges faced by the Department of Defense and the Department of Veterans Affairs in the areas of mental health care. What we find is that when you look at particularly the active duty providers in the military services, there's a significant shortage of providers. And the shortage that exists now is only aggravated by the fact that those providers who previously had primarily worked in a hospital setting now have to deploy, sometimes for extended periods of time, and sometimes repeatedly, and that certainly impacts their retention. We also have found that of the providers that are available in the DoD and VA, really not a large percentage are trained in the evidence-based practices that we would like. So there's limitations to what's available. And when we look at how to address that, and that's sort of in our broad scope, they are looking at the obvious, pay. Can you hire more civilian providers? I don't know how many of you are mental health providers, but it's certainly a good time to be a mental health provider in the world, having gone through a number of years where that wasn't necessarily the case. You can look at increasing the efficiency of the providers through a range of different treatment solutions. You can make the individual provider more efficient in what they do. But you can also look at how you can take technology, automate components of care to make the care actually more efficient and better spread around. For a while, my own read of the literature is that stigma is kind of dying out as one of the key topics. But for a while, stigma had this real sort of, importance. And stigma is not unique for mental health in the military. Although working in a military environment, there was sort of the sense that why does military mental health have such a stigma? Well, even in the general population, obviously, there's a stigma that overlays the challenge of getting people who need care to mental health care, and it's not, the military culture probably only reinforces that in the sense that we have values of strength and you can take anything you need to, take over anything you need, don't be weak. There's even a stigma against physical illness, sort of don't go to sick call. So it's not limited to that. But there is evidence that people who have mental health disorders are also more likely to be concerned about the stigma, and that those who screen positive for mental health disorders may be interested in care but may not be able to get to the care, and the hesitancy to access. So a number of dimensions around stigma. I really struggle with the concept myself, but it is a major theme of why mental health care is not delivered. And certainly if you accept that stigma is a major limiting factor for mental health care, we think that technology offers some nice solutions to that. So anonymous care is, there's a spectrum, I guess I would say, of anonymous care, because from the healthcare billing system, if someone receives care in our system, they go into our electronic record system. And so even though, so they're not anonymous from that standpoint. They could go out to receive care face-to-face with someone else, and that's a level of anonymity that exceeds what they have within our fixed system. But you can think about how if someone could receive the care, not have to go into a mental health clinic, if they could receive the care in their home, that would help address one issue. If you can educate people, public awareness campaigns, campaigns that address the leaders, those could help. But clearly there's areas where technology can help in this. Unfortunately, the military and VA address a large number of people who have physical disabilities, many caused by the work that they do. Those disabilities can impact their ability to travel, their ability to actually just reasonably access care, and the fact that even though our care is free, one of the barriers to care that's associated with receiving care, even if they're close to a facility, is that the travel isn't reimbursed. So if someone wants to see a mental health provider in the military, they don't pay a penny. But if that provider is 2 hours away, they pay a lot to get there. And if they can't drive themselves, they pay the cost of their family member or whatever to get there. This slide, I don't think it does a great job, but it's the best one we could find, that shows, if you see the green area is where particularly in this case, the Army, National Guard, and Reserve are located. And the dots that I think you can see those on there, yeah, reflect where the hospitals are located. So it shows you that there's a lot of people who are not really close to hospitals. This slide does not reflect necessarily all of the VA's clinics that occur, which is one of the ways they've addressed the issue of geographic dispersion. So how do we address the problems of physical access? Well, as I mentioned, the VA's built a number of community-based outpatient clinics and other similar things. The military's done some other work in that area. There's a real interest now in how do you deliver care to the home. Usually that involves technology, but I don't think everyone's thinking that way. Certainly we do when they ask, how do you help us reach the home? Creating smaller places where people can have little clinics. There's clear issues of quality of care management there. There's obviously, some people will argue the advantage is that you can match the culture and the people can better understand the community they're serving, but there's trade-offs there. So bringing the care to the customer, and technology through a number of different methods is how we see that working the best. So it wasn't really a surprise, I don't think, that I led us to technology. Didn't try to be too sneaky with that, and that's how we got here. So let me see if I can catch up again. Probably not, so I'll probably just ad-lib this. People always worry when I talk without notes because I ramble a lot. So we'll see. Okay, so actually this was an article written by a colleague of ours from USC, Skip Rizzo, but who works in the area of technology as well. And this may not be something that you have to think about, but certainly for those of us working in the field of technology, many of the people I work with every day, actually number one is kind of like the opposite. Look for gadgets sake. So, you're not trying to avoid them. You just think, that's a cool. What can we do? And that's part of our area, but matching that to say gadgets aren't necessarily what everyone's looking for. So if you're going to introduce a technology, is that necessary? Is there a simpler solution? Does face-to-face care, do you not need to add in the video teleconference or other challenges that may be included? Much of the technology we work with is at least moderately expensive, fairly expensive on the development side. So ensuring that as we analyze the overall picture of things, that we look at the cost-benefit ratio. The fit between technology characteristics and the identified problem depends on your perspective, obviously. So many of the areas we're working in right now, other people would say that's not a fit at all. And so part of our theme is actually to enable people to see how technology can be a fit for the problem there. So I don't think there's a clear black and white as to whether something fits or not. But one of the other challenges that we've seen or been challenged with is technologies can enable care to be delivered for programs that providers may not be competent to use. And so the awareness that just because you can make it now available, are we delivering in a competent and professionally and a method that meets professional standards. And then finally, is the target population, do they accept this technology? Is this something that they're able to handle? Our target population, as we define it, is typically, it's primarily males between the ages of 18 and 24. So we have a good match to most technology needs. We also serve the family members, which are more often female, and we do service children, parents, and others. So we have a full spectrum of ages, genders, and ethnicity, but the primary group is a nice fit for technology. So just to show that we actually have support from the literature, and I believe that this shows that both you can use technology to deliver care, that people are accepting of care, that there's potential, people are considering using a range of virtual tools online and have done so, both in the US and in other countries. And that primarily through the American Telemedicine Association, there's a real push forward with guidelines and enabling policies to further enable this to proliferate. This is actually the data from that survey, because we actually did that survey. And one of the things that we found interesting was that when you really just ask people, are you interested in receiving care through technology, if you use the threshold of interested, you'll find that across the modalities, people are interested in technology as a method to deliver mental health care. We didn't ask in this survey particularly about virtual worlds, so that was left out. Virtual reality is a topic I'll mention just slightly. We have a lot of research in that area, and it is different than virtual worlds, in case you were wondering. So don't use gadgets for gadget's sake, but they are darn cool looking, and we know that. So we get to play with a lot of these just for fun. And we're actually we have projects in each of these areas, from the mobile, the handhelds, the Droid or the iPhone platform, virtual reality, including the sphere that you can see that one guy standing in. We did a small project with the Wii, and then arranged in some Second Life and some other things here. So back to what virtual worlds are. Now, a virtual world is a three-dimensional persistent computer-based simulation. So three-dimensional, sort of the key difference between a lot of the other work we do. The persistence, it's not flashing by. The interaction is probably the key variable, though. So users actually interact. They're not just observing. And the avatar, we'll get some examples of that in a second. The component of telepresence is also significant in that one of the goals of effective use of this modality is that the individual feels that they're actually a part of the experience. And it's amazing, if you haven't done a lot in this, how easy it is to actually engage people in that manner and actually use it in a therapeutic manner by pulling people into what may, in the abstract, seem totally alien to feel like you're actually there. So when we looked at, I'll never catch up here. When we looked at the options for our building in virtual worlds, we've actually dabbled in a range of these. And there's more. This is not an exhaustive list. But each of these platforms has certain features that make it more desirable versus others. So some allow you to load the virtual world into a secure environment, and then you could have patients log into that securely. You can handle patient data security. You can handle internet traffic security through that method. But typically then those require a specific download, a dedicated machine in some cases. So there's trade-offs. We, for at least our work to this point, have worked in Second Life, primarily because it's downloadable for free. It does have a certain penetrance, although I think I may have the data here, which is that soldiers actually don't tend to reside in Second Life a whole lot, but there are a group of people who do. There's millions of people who live in Second Life quite a bit. And those are the people who would ask the question, is this the Second Life or the First Life? I've met them, and they know each other by their Second Life names, and it's often a little scary. So I guess I'll just give up on these, which means I can maybe give up on these. Why consider a virtual world? It's not the only area we're exploring, but some of what the background as to those mental health needs drove us here. But the virtual worlds can allow people to come together in a way that you can't do with a lot of other things. And hopefully I'll be able to demonstrate enough of that through some of the images that you'll understand that. But I do a fair amount of video teleconferencing. I guess we're VTC'd somewhere right now. And for myself, at least, even though I do this quite a bit, you always know that the person is somewhere else. You never confuse the fact that they're sitting with you. Whereas when you go into a virtual world, there actually is this experience of being with the person. And that's sometimes demonstrated by people will back away. Their avatar will back away in the virtual world. So there is another level of presence that's achieved through working in virtual worlds. And that ties in really to the immersiveness of it. We haven't done any work to assess whether this is a sort of a predisposing characteristic, but certainly some people can feel very comfortable in this. Some people, like those ones who live most of their life there, kind of to a scary level. But it is what it is. We like the fact that it allows patients to receive care anonymously. So you can create an avatar that is yourself, or you can create an avatar that's not yourself. And I'll show you some examples as well of how that can be. The proximity enhancement is actually what I kind of mixed with the shared presence, but you feel like you're there. So someone can be in Iraq and someone can be here in Washington, and yet you go into a room and you're in the same place. Family members can do that, therapists and a patient can do that. You can also create environments that you can't really replicate in real life. And we'll show some examples of that, particularly for exposure therapy. You may not feel like it was a great choice to make a room full of snakes and put a patient in there, or put a patient on the top of a crane, but in Second Life you can. So you can do some things even beyond. And those are really where the affordances of virtual worlds become key. And then the interactions, you can collect enormous amounts of data very easily, so you have the ability to measure as you're going along. Some of the reasons we did this is the first image I think I have of our virtual world. It does provide opportunities for anonymous access. Education is kind of the low-hanging fruit, but also it's not really a great affordance to this. People can come to virtual worlds and get education. In general, unless it's interactive education, it doesn't really offer a whole lot more than the click-through PowerPoint slides or the lecture format. But there's a number of ways where actually care can be improved, and that's what we're dedicated to, is figuring out how you can take advantage of the interactions you can have in Second Life that you can't have in real life, how you can use this to help bring providers together and bring providers up to a standard that perhaps doesn't exist in the real world, and then the ability to consult also can improve care, as experts can reach out pretty much seamlessly to wherever they are. Sensitive to time. This is actually Kevin Holloway, this top picture. In real life he has hair, but he decided to make himself bald in Second Life. He's not the guy below, although I think he created that one too. And this is to show you can be a human, and most people are human. Most people choose to be the same gender when they go into Second Life. Most people actually augment their physical characteristics, however. Very few bellies and short, kind of pudgy people. A lot of tall, very figured people. But not everyone. So Kevin took his hair away. He actually has nice hair. So whatever. You can be who you want to be. And you can actually explore being different things. So you could explore being a different gender, and some people will. You can explore being an animal, which, quite honestly, I don't think I have trouble with figuring out what that really means. But you can do it if you want. That's sort of future stuff. Once you got enough people in here, you could explore the dynamics of that. But you can also not be a person if you feel that that's a safer way to be. We've also looked at wheelchairs or handicapped, and you can see how people treat you or how it feels to be interacted with if you have a different characteristic that may be prejudicial. So, what we've created, and I say soon because this is kind of my world, is my world, I don't know if it's real life or Second Life, but in the Department of Defense, you can't do anything without huge bureaucracy. So we've been working on these forever, and now we finally said, okay, we want to just make them available. And they could be available, but any day now, we're going to be told we can make them available. So that's why soon is up there rather than a date. We had a date, and that date passed. That's the DoD world. But what we're offering, and I'll show you a number of images of, I don't think we think the video won't work, but we'll give that a try too. That allows for experiential, immersive experiences. Our focus was on PTSD. PTSD still is sort of the signature injury of war for this version. We won't get into the TBI versus PTSD debate. It's supporting self-assessment and accessing care through this. And there's a lot of things that can be done with these islands. So what we took on as challenges when we built this is there really isn't a lot in this area. We're clearly not the first to think about putting mental health services in Second Life. But what we're trying to do is represent it in a professional manner, focus on the fact that we may or may not, we're not trying to identify patients, so we're emphasizing anonymity, which means that we don't know if the person we're seeing actually is who they say they are, so that guides certain principles about what therapy you can offer. But making it available 24/7 really helps in our population, which is deployed around the world. There's, like everything probably in the world, there's continuum, how much control you give the individual going through the environment versus how much control you take over them versus how much choice you give them. We've tried to find a balance there. In certain areas we take control because we think that's the best way to ensure they get the experience that we think they should. In other times we've allowed them to have choice because that's really what it's about. But if you allow full choice, you really can't ensure that they get the experiences that they should. We've tried to say that, again, the easy thing to do in Second Life or in virtual worlds is you put up a series of information slides and you just show them through that. You can do that actually quite easily. It looks a little cool, but it really doesn't add anything. So we've de-emphasized that. We've tried to honestly represent what we are and who we are, and then the importance of respecting the people in it. Even though you may see, if you spend any time in Second Life, that that's not necessarily a shared value of everyone who inhabits Second Life. Sometimes there's a group of griefers who go around just basically, bothering people. That's their role in Second Life. I guess maybe that's equal to the real world. I don't know. So on the area of educational learning, I like this picture because I can just see this guy. To me it shows how little it takes maybe to live a dream. I don't know who he is. He's not actually someone who works with us.
Dwight, from the office.
Oh, it is Dwight. You're right. It's Dwight. That's why I was confused. I thought I knew him, and I didn't. So he's living, and he had a whole segment on it, didn't he? Someone told me. An episode. So that's probably how everyone knows Second Life, right? Does everyone watch The Office? No. I haven't seen that episode, but I do watch The Office sometimes. So this is Dwight living in Second Life, a better life than he has in his office. And you can imagine, I've been in some University of Washington facilities that are amazing. I can't remember what they were, but they had that view over there, so maybe you don't need it there. But for the rest of us, it's great to have the fantasy of actually interacting with fun people and seeing nice places. Oh, some of them are probably watching right now. Sorry about that. We're trying to take advantage of the opportunities that are here to engage people in challenges. So games often will, even simple games, people will compete. And if you can get people competing, you can often get them to engage in an activity much easier than if you just tell them, you're going to have to do this for the next hour. And they will engage mentally and remember it more. So looking at how you can leverage that. Lecture series is, again, the easy but not necessarily compelling. But you can bring people together in this environment, and they can be in an auditorium and work together. And then our constituents, the service members, so the military members, their spouses and families, their supervisors who are non-commissioned officers and commissioned officers. Those are a little harder group to get to tackle. They tend to be a little older, a little more sort of institutionalized. And then the opportunity that this offers to reach the community at large, which is not, we're funded to reach a certain beneficiary population, but through programs like this, we're able to reach a more broad population without an incremental cost, and so nobody worries that we're spending defense dollars to care for non-defense beneficiaries. And that makes everyone happy, I think. Was this the, let me see something. Okay, this next slide we think won't work. We tested this right before, but I just have this desire to double click on it a couple times and see if it shows up here right now. but I'm not getting a good feeling because that finger's still pointing the same way. So, fortunately, working in the area of technology, I learned that you always have a backup, because while technology is really great, it also can be a challenge. So, these slides actually, what we created, and you'll be able to see soon, I think the press release will actually hit a wide range of people. You'll be able to go into Second Life. Again, if you don't have an account, you can make an account on your own. You can go visit what we have to offer. It's not open yet. It's hidden. It's there but hidden. But what these are is, what we had created is, within Second Life, you can actually create movies. And so we created a movie to try to show you what it's like to move through it. And if you don't have that experience yet, this doesn't quite capture it, but this shows you the visual images in 2D of what we have. So we chose a theme that was patterned after a state park. We thought, Northwest, nature, makes us feel good, so why not choose that? Really, the first place you enter is you need information, and so when an avatar chooses, so to give you a big picture of Second Life was started by free spirits who were really kind of counterculture, I think. It was intended to be a place where communities could form their own ideas. And then it was, in many ways, taken over by sex. So sex dominated the entire Second Life world. And that drove a lot of people, it's like, well, it drove some people to it, and it drove other people. It was hard to do professional presentations showing Second Life, because you never knew what would show up in your presentation. That's been addressed. Yeah. Maybe it'll be more interesting. I don't know. But what happened is, because Second Life had an interest, or the people managing it had an interest in allowing it to work kind of in both spheres, the sexual content of Second Life has largely been segregated. But it still is, I think, a major activity there. But then there's other things. So people can come here and do any range of things. You can go to a dance, you can go to a party, you can go shopping, you can go travel the world. So people have recreated all sorts of places in the world. So that's the kind of where you are. And so this is one of those places. In Second Life, the land is called islands. And so we've got a series of islands that are put together. And it kind of feels that way when you're in there. You can fly between the islands, and so you land there. They're not necessarily spread out the way the world is. And you can teleport, essentially, from one to the other. So you don't have to take a long time flying between Europe and the continental United States or something. So we offer at the initial phase a place to learn some basic information. We offer, you can acquire this heads-up display, which sort of is a measure of how you're doing. And then it shows you a map, kind of, basic orienting. And this is roughly what it looks like. It changes all the time, so it looks something like this. And looks like this is the inside of our space. It's really nice when you live in cramped quarters to be able to fantasize that there's no limit, and that's kind of the way this works. So we have, I don't know how many gazillion square feet of space here, and this gives people a view of what's being offered here. To this point, we're not directing people. This is people come in and they can choose. There's obviously a logical location where someone would start, but they can browse. The heads-up display, we've actually changed this from panic to, I think, relax. But some of our early feedback we received was, what if this is so realistic that people get scared and you've now created a problem? So the world we live in is, maybe that's some of you guys too. That wasn't where we were thinking. We were thinking, we hope we immerse them in this. But it's a reasonable question. And the way we've addressed it is to say, just like therapy might do, what's a safe place? How do you sort of back out of this and get to a place that allows you to feel safe, as well as in our future iterations really allows you to measure and maybe increase your sensitivity to your own stress or anxiety. That maybe one of the problems is that the individual is not aware of how they're doing. And this can help through the experiences to suggest to them that maybe they are feeling an increased level, and maybe this would be helpful to be more aware of how they're responding to the situation. So the panic room, again, I'm not sure what we call this. Not the panic room anymore. But this is one. There's actually several options you can choose. So this is the beach scene. You can all of a sudden teleport yourself to the beach. You're sitting there. It's a way to, It can be countertherapeutic. So depending on your view of exposure therapy and, are you reinforcing avoidance? But because the general experience that we're offering here is not one that's guided by therapy. This is not treatment. The importance of ensuring that someone is not harmed outweighed the concern about the fact that we may be inadvertently reinforcing avoidance behavior. So this encourages some healthy, relaxing behaviors and allows the individual to then choose to come back, or maybe they can just leave. If they found this too traumatizing, they can just choose to say, thanks, but I'm not going to come back here. We have an area that looks at helping people to understand what may have caused their problem. Again, the focus is on PTSD. The theoretical rationale or underpinnings are primarily EPT, but this shows simulated war scenes. It provides information about how the therapy links to that. We do offer a controlled experience here. This is where we actually allow or put people into a vehicle. They can choose to get in the vehicle, but once they get in the vehicle, they get driven through a controlled experience, with the goal being that we want to ensure that we know that that's one way to show them what the experience is. Most of the time in these islands, you're walking around yourself, and you can bounce over here and bounce over there. If you want to get someone an extended experience, you have to take some control over their avatar. I'm realizing that I'm probably going to speed up here a little bit, trying to be sensitive to the time. So this is pretty picture. This is actually, for the experience, this is an important point, I guess. We've allowed people to identify if they think they're capable or what they want, what level of experience they want to get. So they can get the mild experience, the moderate, or severe. And that was, again, an attempt to titrate the experience. I'm sure some of you are saying, yeah, right, you'd be lucky to get people that affected by this. And I can see that, but again, being sensitive to the impact this may have on individuals who really do experience this as a real and potentially traumatizing experience. So they get into this. This is we don't have an MRAP, so this is the old Humvee model. One of the challenges you face in anything you do with technology in the military, particularly now, is we're changing our equipment so quickly, you may not have the right one, and soldiers are sensitive to that. The vehicle goes through, so the individuals get into this vehicle, they go through this experience. There's blood, there's sound, and then they can, and let me go back, sorry. Oh, that worked, okay. So there's blood and sound. This is an explosion. This is one of the typical traumas that's, something around this. IED explodes and kills some people. And the experience is obviously three-dimensional. The individual's in there. And so you can work with the individual over what that experience was like and whether this is re-traumatizing or causing other difficulties. When people leave the theater, they obviously fly back here. And so this is replicating the departure experience with the idea that you can now use that time in a constructive manner to help inform individuals about alternative strategies and what they can learn from their experience. And so on the airplane, you can show the movie. Again, this is the person decompressing. One of the challenges or the questionable challenges has been, do people have an opportunity to adjust back to the United States, to a non-war environment? There's an argument that you need to be hyped up and you need to be in a different mental state when you're at war, and that's good and healthy, but you don't need that mental state when you get back here, and this is an attempt to address that. A shopping mall is interestingly, if you're not in this area, is actually a very high stress, high frequency, high base rate stressor for individuals with PTSD, at least from the military. And so we created a number of scenarios around a shopping mall because that will lead to avoidance. And so the avatar can go in and address those. It allows individuals to work therapeutically with that environment. So you can not only talk about it and say, well, so when you go in the mall, what's the thing that's traumatizing you? But you can re-experience it. So you have the opportunity to say, now is this a problem with lots of people around, or with a small store, or a store that's selling X or Y or whatever. Some of the objectives, I'll move quickly through this. Arcade is another place, as you might imagine, if you're feeling a bit edgy. I can't stand these things myself. In addition to my college kids, I have a 9-year-old son, and so I avoid these just because I can't stand them. Noisy. So this is a place where you can take people that will stress people out, a lot of people. This doesn't work well without the video, but allowing people to engage in healthy competition where they're trying to improve, do better, experience more, relax more, really trying to engage them in a concept that you can do, that you have other peers out there working on the same issues, and you can earn points through a number of different methods that will help you do better. And we've found that that's actually quite engaging concept. So I'm hopeful that's the last of the one set of slides. So where are we going to go with this? I recognize that without the video, if you're not experienced in this, you're kind of probably going, I really am not sure what this would be like. And reflecting as I'm speaking, I'm thinking you may be saying, well, how do you use this? So that may be a question we get is really, how are you using this? The idea, just to share with you, is that right now we're creating the environment for a range of uses. So we've had VA providers who say we want to use this therapeutically. So we're going to take our patients into there and work with them through exposure therapy by taking them into this during a therapy session. There's also people who expect that people will use this at home or remotely. Patients, providers may follow up. But that's not what's been driven to this point. To this point, it's creating the environment to enable those projects to move forward. We do a lot of work in my center looking at screening for mental health disorders, screening for suicide, screening for a range of things. And so embedding those into this is a goal we have, and a method that might allow us to achieve a better penetrance. We're also interested in studying whether or not the correlation between sort of the avatar's scores and the individual scores, which is something we should have the data for. There is a theory that goes on, are you treating the avatar or are you treating the person? So you can have a really healthy avatar in the end, but the person's still all screwed up. We hope that's not the case, and that's part of what needs to be studied in this whole equation. A couple of acronyms I know. So we're looking at, can you use this for scheduling? TMA is the military headquarters in the VA scheduling. So how can you use this to arrange for care? One of the biggest challenges, particularly when you're remote, is how do you identify when that individual is available? It's hard enough when you're in the clinic itself and you can go look at the sheet of paper or whatever, but when people are on different time zones, how do you figure that out? I'm not sure what I wanted to say here, so we'll just move on, but it's just a nice, relaxing scene. The Courage Theater. This is a place where, again, the concept of it takes courage to be in care. This helps to build skills and strengths. We have resources here that people can use, information about accessing care. A conference is, again, a fairly easy thing to do. Last summer, we held our first Virtual Worlds conference over at the Seattle Science Foundation, where we actually had 50 people in the conference room there and a comparable number online. Challenges of having that mixed modality we find, but it does work, and you can bring people in who can't travel or choose not to or whatever. This is our conference center. Yes, we are on the water. Yes, it's really cool. So, where are we headed? Because this is, so far it's been a closed environment. We've done focus groups and some provider exposure groups, but what we're expecting is now that it becomes open, we will be able to more easily obtain user feedback from a range of different groups. And that will lead to refinements in how the actual program is deployed. That's our expectation. We don't think that we've built the perfect solution. We've built something that we think is good and will be useful and will allow that next level of work. We're aware of two areas that we're focusing on shortly. We kind of have in development right now. Helping people sleep. Sleep is a big problem for a lot of these individuals, and mood disorders are certainly also a concern. The concept of delivering clinical services. We've developed the concept for a pilot study looking at actually seeing a patient through a virtual world. We haven't gotten it through the IRB yet, so I won't tell you that we're going to do it, but think about that, going to your IRB and saying, we're going to see this patient who has a mental disorder. We're not going to see him. We're going to see him in virtual worlds. Our IRB is pretty tough. We'll see. We think we have a solution, though. Using it for provider training and then using it as an augment to clinical care, we think that is an acceptable first step that many people will allow, and that will then disabuse the IRBs to the concept that you can deliver care in this, and that will then allow us to look at how you could actually deliver care through a virtual world. some of the concerns people have, some people say, well, are you just making things worse for people by allowing them not to get out of their room? It's an empirical question. Are you creating different types of problems by comparing? Are you not allowing people? Are you not mixing the right groups? I don't think this is a big issue anymore, but that whole thing of sort of internet. My spouse has abandoned me for their internet friends, kind of thing. Is this going to cause other problems in relationships? But how can you? But the opportunities are there to normalize. People can now experience and share with others who have similar problems and maybe recognize that it's not so unusual. You can share the experiences, so you can actually better. You can bring in someone who hasn't had that experience and allow them to experience it more closely and say, that's what it was like, in a way that you really can't do with just words. So there's a lot of opportunities there. With that, using this as an augment to telehealth, we do a lot of work in virtual reality. We have a big randomized control trial looking at prolonged exposure therapy with virtual reality. What is virtual reality? It's augmented reality. Can you use this without bringing in the expensive heads-up displays and other things that we have as part of our virtual reality? This is our clinic. I want to have some time for questions. So NICO is a big... so some of the challenges... no, I won't actually talk about those. I'll speak a little bit to this. So if you increase utilization by reducing stigma, unless you have some way to increase efficiency, you're not necessarily addressing a problem. Because if there's a shortage of providers to begin with, you may be actually increasing the problem because now people want care. And if you don't have the care to give, is that actually solving anything? But if you can offer useful tools that allow care to be delivered in more efficient ways, you are. If you're going to deliver this for clinical care, you obviously have to know who you're caring for. You can't allow you can, but there's certainly different type of therapy would be delivered if it was anonymous than if you knew who the person was and you knew they were telling you the truth and you knew a number of other things. And then some of what I alluded to is the facade of the avatar. Is that really the person, and are you really treating the core issues that they're facing? Right now, to run this, you have real people running real avatars. There is the ability to use artificial intelligence to automate certain aspects, but we're nowhere near automating therapy. So you still need people engaged in this. Again, it's a distance solution, and it offers some other needs. And a lot of clinicians are a little wary of this. I don't know why. You also have the traditional problems we have with telehealth, licensure, and regulation. Right now, virtual worlds are no one knows what to do with them. I went to a conference on virtual worlds with the Federal Banking Agency, and Federal Bank, whatever it is, and they were talking about, can you tax it? Whether you can do it. No, there's no taxes now, and people do earn a living in here. So issues of professional competence also cut across this. And right now, there's no credentialing board for virtual world therapists. And if there was, how would you verify that they were who they were supposed to be? If you wanted to match therapy styles, whatever. I mentioned griefers early on. Griefers do a range of things. They try to shut down some activities. Sometimes they just do a range of things. So making sure that's controlled so it doesn't add to the problems you have. And then what's built in here, controlling that. There's a whole range of laws still being developed on who owns what, and as you move forward, and can you continue to use it? Can you share it? One of the nice things we have is we're not a profit-driven agency. We just take all of your money and use it for our purposes. So, and because of that, we can give away what we have. So we can't make money. So what we build is everyone's, and we like that because that makes us feel generous. It's really your money to begin with, so we're happy to give it back. So this slide is my sort of caveat. This was written, I think I have the quote. Let's see. Yes. This was written in 1898, so lest we think that virtual worlds are going to solve all the world's problems, unless we think the telephone did already, maybe it's not, but it is a nice thing to fantasize about. So with that, I have 6 minutes for questions, I think, and I was told... Do I have to exit out of this to get that other screen? Okay, I was told there's an online questions. There are no questions. Well, thank you. Does anyone in the room? Yes.
Hi, thanks for your presentation. You know, I'm guessing that the virtual world, as far as for clinical therapeutic purposes, is because of the anonymity, and I would think that somebody would want to have anonymity more with their own peer group than with the therapist. So why not just have live, live therapy from client to clinician in their own private setting, rather than having to come to a clinic or a hospital?
Are you asking in virtual worlds or outside of virtual worlds?
Outside, I mean,
Got it.
still doing,
Right. Home telehealth to the home.
Yeah.
We actually have a project that's been funded with Portland VA to start doing telehealth to the home directly. Within our system, it's been determined to not meet the standard of care. So that's with our policy. The DoD policy folks for medical care have determined that doesn't presently meet the standard. So the way we're addressing that is through a formal research study that's going to look at delivering care to individuals' computers at their home. We do presently do video teleconference care between patients and providers, but that has to be at two hospitals. So they can go into one hospital where there may not, or a clinic where there may not be a provider, and see another provider at our hospital. But this is the next extension of that. We call it the return to the home visit.
Well, sure, because the clinical, observation that's made, there's so much that you see that you don't hear, and if you have avatars, then it's going to be clouded even more.
Certainly, those are real concerns. I mean, people have that concern about the video too, right? That you're not getting the full perspective.
Right.
We like to think, again, I'm admittedly biased, but particularly with the home telehealth, which we've gotten the most resistance to, is that's like the old days when you could do a home visit. So not only, while you may get some noise in there, you can also learn a lot about the family, whether the individual can even get an hour alone in their house, or whether people are always bothering them. You can actually have them walk around and show you where they live. So depending on what you believe is valuable augmentation to care, you can add to it, or lose, because you're not there. You can't smell them right now, at least. So sometimes that's a key, I know.
Right.
Any other questions?
Thank you so much.
Okay, thank you.